Good afternoon. My name is Francis. I'm going to be presenting my M&M today. I'm really excited to share this case with y'all. It's really left a mark for me. It was a really good learning case, but also one of the saddest cases I've been in. So yeah, let's get into it. All right, so for the typical disclaimers for M&Ms, we're going to keep it for educational and keep our conversations focused on improvement. There's no individual blame. Our objectives are to define and understand basic safety terms, adverse event near misses, root cause, potential errors within the system. Most medical errors are systemic errors, most if not all. So learning how to view the holes in our system and where we can improve that, as well as recognizing and defining types of medical errors. And some of the educational things we'll be talking about is PCP patient panel size, bronchoscopy, and touch a little bit on pancreatic cancer as well. Okay, so I wanted to start off first with a board question in light of it being April, so the third years have been studying. We have, so we have a 30-year-old female. She comes to your office for evaluation of a 5-millimeter pulmonary nodule noted on CT chest, performed after a motor vehicle accident 2 weeks ago. She has no symptoms. She is not a smoker. Physical exam is unremarkable. Which one of the following would be the most appropriate at this point? We have A, a non-contrast chest CT in 1 year, B, a PET scan, C, a referral for a needle biopsy, D, referral for bronchoscopy, or E, referral for wedge resection. And I can go back and look at my chat if y'all want to put it in there, or you can unmute. You can give me the chat.
And I actually can monitor your chat for you.
Thanks, Dr. Simmons.
Go with A.
Is that Bailey?
Yeah.
Dr. Willoughby, great job. Yes, the answer is A. Go to the next slide. And this is because by definition, pulmonary nodule is can measure up to 3 millimeters in size. And usually the management's based on the probability of it being a malignancy. So risk factors being like lung cancer, previous malignancy, positive smoking history, or age greater than 65. And she doesn't meet any of those high risk factors, not being a smoker and being 30 years old. Really, nodules less than 8 millimeters are really difficult to biopsy, and PET scan wouldn't be reliable for it. And the risk of surgery outweighs the benefits for nodules that small. For a low risk patient, anywhere from 4 millimeters to less than 6, they really recommend repeating a non-contrast CT at 12 months. And then if that is unchanged, then there's no further follow-up that's really recommended. Any questions about that? All right, so the case is we have an 82-year-old white female. She's got a history of chronic bronchitis with dyspnea, HFpEF, COPD, aortic valve replacement, AFib on Coumadin. She's followed by cardiology and pulmonology. Socially, for 82, she's very independent. She lives with her daughter and her boyfriend, but really manages her own bills, her own medications. She has her own hobbies. She's very independent and still drives, so quite remarkable. She is presenting to Union on January 20th for a routine bronchoscopy to work up some lung nodules seen on PET scan. And after she had this procedure, she was called for admission to medicine for worsening respiratory status. Some more of her history: she's had an aortic valve replacement in the past and cataract surgery. Family history is remarkable for pancreatic cancer in her brother, who passed in his 50s. She is a former smoker, 50 pack years. She's been quit for about like 20 years though, and no vaping and rare alcohol use, some allergies. Here's her medication list. So she's on quite a bit of medications. A lot of these are for chronic things, like the warfarin, Effexor. She's got some Lasix for her heart failure, metoprolol for the AFib. I highlighted her inhaler treatments. So she's on good timing with Sharon's presentation, which was great and very primary care oriented. So great job, Sharon. Trilogy, ipratropium, and albuterol. So she's on a pretty hefty amount of inhalers with her COPD. So that's the biggest takeaway from her meds. So here's some background before we get to how she ended up in the hospital for a routine bronch. December 31st to January 5th, she was admitted for COVID pneumonia and was had some incidental nodules noted on her CT. This is the impression of her CT. So there was some concerning findings for multiple pulmonary nodules suspicious for a neoplastic process and metastases, as well as this 2.5 by 3.3 paramediastinal left upper lobe that the radiologist noted could be neoplastic or inflammatory, and then some other findings of lymphadenopathy and pneumonia. She was treated with steroids and antibiotics and got better from her COVID and discharged home. Before her discharge home, the hospitalist team ordered a PET scan and wanted her to follow up with pulmonology after the PET scan, depending on the PET scan results. And I wanted to say really quick with this is quite a large mass. Like we discussed before, anything less than 8 millimeters, so that'd be 0.8 centimeters, would not be concerning when we do follow-up, but something this big, it was warranted for further workup. So here are the PET scan results that came back on the 5th. It did note a hypermetabolic left upper lobe and a left inferior hilar soft tissue lesions that were worrisome for possible synchronous primary bronchogenic malignancy. There's some other metastatic nodules noted. And then at the bottom of the report, there was this concern for uptake in her pancreatic head and proximal body locations, as well as mild pancreatic atrophy. And they actually recommend further assessment with an MRI abdomen with MRCP to assess for underlying primary pancreatic malignancy. So this lady who has had no symptoms other than getting COVID incidentally, and they found all this on her, now is diagnosed with possibly 2 primary possibly metastatic lung cancer versus pancreatic cancer. So it's a very serious diagnosis. She then followed up after hospital discharge with her PCP on the 10th. Per that note, a pulmonary mass was noted and patient did have pulmonology already scheduled per discharge from the inpatient team. They noted that it looked like possibly a primary lung malignancy per the testing, and that the tissue evaluation would be needed to characterize that. There was just a brief mention of the pancreatic mass, but no details about it being spoken with the patient or the family. The patient was then seen by pulmonology as scheduled on the next day, where the pulmonologist also agreed that she should be scheduled for an urgent bronchoscopy, and they mentioned the pancreatic head and seen on the PET scan, but there wasn't really anything regarding any discussion of any further testing for that or any CT scans or MRIs to work up the pancreas. There's just it seems like the urgency was to get her into bronch so that the nodules could be biopsied. So this is a general overview of the events when she came to Union on the 20th for her scheduled elective bronch. At 10 a.m., her bronch was finished, and she now had overt hemoptysis and required intubation again. She required intubation initially for her procedure, was extubated, and then required it after the hemoptysis. And at 12 o'clock, she was extubated on 15 liters, and this was when she was called for admission to medicine. At 12:30, she was seen by the medicine team and by pulmonology, and there were orders placed for imaging and lab work, as well as TXA infusion. She was still bleeding and having massive hemoptysis. At 4 p.m., she was called, the medicine team was called for worsening respiratory status, and comfort care orders were placed. So this happened very quickly in the span of just half a day, pretty much. So we'll go more into detail and break this down. So at 7 a.m., she was admitted to Pulm, and this is the pulmonology note. The daughter did notice that her mother looked extremely jaundiced when she first appeared to the procedure room, and this was noted, but the procedure moved forward, and they cleared her to get the bronchoscopy. She had the DNR, DNI. It was reversed for the procedure. So at 11:15 was when she was done with the procedure and noted to have profound hemoptysis. She did desat down to 78%, so they intubated her to protect her airway, and did look down in her throat to see if they can find the source of bleeding. There were some clots removed, some suctioning was done, and when they did as much as they could, taking out all the clots, she was extubated, put on mechanical ventilator, and put on 15 liters. And in the note, it also said that pulmonologists discussed the updates with the family, and stated that if she wasn't going to stabilize today to go home, then she'll need observation for the next 24 hours before returning home. So the call to medicine happened at noon, and it was given as PCU for observation status on 15 liters. But the nurses were very concerned about her, so the medical resident went up to see her sooner rather than later. She was seemed very tired from breathing. She had her non-rebreather mask over her face. She was speaking complete sentences, but tiring quickly. There were the thick clots of blood seen on her lips. She was also overtly jaundiced appearing, and had some subtractal contractions with her breathing as well. Blood pressure was 119/96. Temp was 98, pulse was 108, respirations were high, 29, and got an immediate ABG, which resulted in some non-GAP metabolic acidosis, but not particularly worrisome, just at a glance. And I also went ahead and ordered the ABG, the CBC, CMP, further workup of what could be causing her bleed, and got the chest x-ray. So something to note, her initial labs from her original COVID admission, her liver enzymes were actually all unremarkable. She wasn't jaundiced at this time. And the initial labs that we got at noon did demonstrate this overt elevation in her liver enzymes, as well as her bilirubin, hyperbilirubinemia. Her X-ray demonstrated some worsening parenchymal status, but the X-ray was not able to rule out pulmonary edema versus infection. Another thing was that we never got a CT on her, so it was hard to characterize whether the findings on her X-ray were blood or infection, since they all appear similar on the chest X-ray. And this was her chest x-ray. So you can see a lot of areas of congestion, likely representing blood and hemorrhage, some pulmonary hemorrhage. So the pulmonologist on call left a note shortly after and was suspicious for pulmonary arterial bleed from her recent biopsy, and immediately put in for transexamic acid and nebulized transexamic acid, checked in and gave orders to check INR and give FFP if INR was elevated and to start empiric antibiotic. He did also note the hyperbilirubinemia and the possibility of this being pancreatic head cancer, of course, and then the respiration, acute respiratory failure recommendations for Dulunab. So she was started on transexamic acid at 1350. The medicine team was called to bedside for worsening acute respiratory failure around 1500. The patient did remain to have decision-making capacity and desire to go comfort care and these orders were placed at 1600. Her INR was initially elevated at 3.4, but due to some complications with obtaining the plasma or the platelets, it wasn't started until 21, and then her INR had improved after that. But her daughter was at bedside as well, and as of course, it was very daunting for her to hear about everything that was going on. She had just brought her mother in for what was supposed to be, a really routine outpatient procedure, and now was getting told she had this diagnosis of pancreatic cancer, and that her mother was actively asking to go comfort care because of how much pain she was in, trying to breathe through the pulmonary hemorrhage. The next day, she was pronounced deceased after comfort care orders were started at 9:29 a.m. on the 21st. This is her pathology exam. It returned about a week or so afterwards with mildly atypical columnar cell findings, not diagnostic of malignancy. And pathologists also noted no features of diagnostic malignancy with that scant sampling that they were able to obtain. So this by no means was like a fully diagnostic testing because of how little the sampling was that they could obtain. But the family opted not to get an autopsy. So that concludes my case. Before we move on, are there any questions or clarifications about anything? Okay, then we'll move forward.
Francis, I have a question.
Yes, go ahead.
You might have mentioned this already, but I don't think I knew where the case was going yet, so I missed it. She was on warfarin, right? And was that stopped before her bronch?
Yeah, that's a great question. Yes, so her warfarin was stopped per the usual, I think it's 5 days. Whatever the protocol was that pulmonary gave her, it was stopped for 5 days before her procedure. But that's a really good question, yes. What do y'all think? We'll open up the floor. Was there a medical error?
Just because it's silent, I'm not sure if there was honestly a medical error. The only thought I really had, I was like, I'm pretty sure this was like an 86-year-old female. Is that correct?
Yeah, she's 82.
82. I kind of just felt like maybe a little better risk stratification may have been the only error. From if I missed something, maybe not, but from what I see, that's kind of where I see the error, maybe.
Yeah, absolutely. So, that's a good point. Well, so like preventative wise, before her procedure, maybe having some better risk stratification, and for that to be explained to the patient before proceeding with the procedure. Anything else?
I might have missed this, but did you say if they obtained PTINR, PTT before the procedure, or was it just after when she started bleeding?
It was just after. They did not get any labs before her procedure.
And she was on warfarin before the procedure?
She was, but oh no, she was off of it for 5 days. Um, so I didn't see her outpatient lab work. I'll have to check. That's a good question. I'm sure they checked that and made sure she was okay before starting, but on the day of admission, there were no lab orders.
Yeah, so I think the only thing that I could think of is for someone who's been on warfarin, even if they've come off of it for 5 days, if they have what we are presuming is a malignancy, like she's already more likely to bleed. So it would be good to check, like recheck the INR, just be like sure before doing an invasive procedure with risk of bleeding.
Okay. Yeah, great thought.
I think the family had mentioned some concern about jaundice and potentially, even if you didn't know she had possible pancreatic malignancy, even thinking about like, could she be coagulopathic? Maybe not the safest to continue with the and more elective, non-urgent procedure.
Yeah, absolutely. The family was very concerned. Go ahead. Yes.
No, I was just saying that's true.
Yeah, so it kind of makes us think, should she just have been admitted for overt painless jaundice, the medical service, instead of proceeding with the procedure? Was there an adverse event? Is the next question. And I can answer this one. The adverse event would probably just be the death that occurred. Does anyone else have any other thoughts?
I was thinking the bleed would be the adverse event, like the post-elective bleed, because they didn't may check all the labs, assuming they didn't check all the labs beforehand.
And did the medical error cause the adverse event? That's a hard question because it's hard to say causation equals causality. Like, even if we had checked all those things, would this still have happened?
I feel like it's very possible that yes, especially if she came in jaundiced. That was something that we probably could have caught.
And then one other thing I wanted to mention too was that instead of another way to go with the bronchoscopy, because I think the idea behind where the care team was headed was they wanted to characterize her lung cancer, and the findings on a PET scan regarding pancreatic cancer were actually not even disclosed to the patient per the family. When they were admitted, that was the first time they had heard anything about pancreatic cancer. So maybe if they were given the option to go either with a biopsy or with the CT or MRI of the abdomen, they may have chosen the latter, and that could have changed the course of her management as well. So that's something else to think about. So definition of a medical error is failure of a planned action to be completed as intended, or use of a wrong plan to achieve the aim. Or an act of commission or an act of omission, and then adverse effects are negative patient outcome as a result. So in terms of the root cause analysis,
Francis,
yes.
I'm sorry, excuse me.
Go
I
ahead.
don't think you could see my hand was up, and Dr. Patel's hand is up as well.
Oh, I'm sorry.
Just a quick question. For this patient, did she Was there any documentation in her initial inpatient visit where, again, when the scans were showing all these masses, was there any documentation of discussion with patient and her family?
Yes, so the scans were discussed through the PCB visit and through the pulmonology visit. I'm not sure on the inpatient side if they really discussed it. The note didn't say it. The note just mentioned that they did the PET scan, they discharged her with close follow-up. So I'm not sure what they told her. But the notes from the follow-up visit with the PCP and the pulmonologist, they did discuss her lung findings. There is no documentation of discussion of the pancreatic findings.
Okay. And Dr. Patel had her hand up.
Oh, yes,
So
go
my
ahead.
question goes sort of in line with that. That was the error in agreeing to do the bronchoscopy, which was an elective procedure if the patient might have known that she may have another cancer.
Exactly.
So that could have been better documented if she had clear DNR or DNI outcomes, but she knew that possibly she could have two cancers, one that could be aggressive with the pancreatic head mass. Would she then have elected to go through a elective procedure that could carry a risk to it, or kind of do an observation that may have extended her life? So in terms of not just even the procedure and its side effects, but whether the procedure was the right thing to do at the time.
Yes, absolutely. That was really well said, Dr. Patel. Yeah. So that was my biggest, that was the biggest thing I saw when I was going through her case, was that the pancreatic cancer was not mentioned and the patient really wasn't given options. So it seemed like it was kind of rushed just from the notes to get her in, to get the bronch and work her up. And there was this urgency to it. So I think that was a good discussion we had kind of the root cause analysis, kind of all these things that lined up perfectly for the perfect storm to occur. And we'll go into some of this in more detail. Let's see. And some of the questions we want to think about is what are some of the system and individual contributors that can be identified as medical errors, and how can we prevent future harm by eliminating this error? Something to remember too was on that PET scan, I highlighted and bolded and put in red all the recommendations from the PET scan but that was at the bottom of the report. So in a busy day at clinic, I mean, it's very easy to read number one and get caught up in other things and move on. And these things at the bottom of the page sometimes get missed, even though sometimes the most important things get put at the bottom. So that is kind of like a systemic error. One example of one. Okay. For the physician peer review for the RH harm scale, this patient did result in death. And then for the please check one of the following, do we think that the standard of care was met in this case? Anybody who believes that that is a yes and wants to speak? Okay, what about practice not necessarily consistent with established standards or standard of care questionable? Anyone think it's that?
Dr. Yu?
Yes.
Yes. Make a comment. I think that when you look at the standard of care, was the standard of care after the incident happened, was that met? But I think that that may have been met. But as Dr. Patel talked about, the standard of care prior to even scheduling or having the procedure, I think that's where it's questionable for me because again, was the family and the patient given full options or full understanding of what was going on in order to inform the next step of exact diagnosis and possibly treatment from there. So that's what I would think.
Okay, great. Thank you. I think that was a great way of putting because it was kind of like two different things that happened, her actual hospitalization and all the acute sort of like ICU traumatic things we had to do to stabilize her versus the things that kind of led up to that. So I think that was a great summary. Anyone else have anything to add?
Yeah, I mean, I agree with all that. I'd also add maybe, I'm not a surgeon, so I don't exactly know protocol, but I'd assume if the family was like, oh, this jaundice is new, maybe abort surgery and work that up before continuing. But I don't exactly know their protocol, but I'd assume that was that the standard of care wasn't met.
Gotcha. Yeah, great question. I'm actually not sure. I think that might be more of a maybe it's more of a surgeon decision at that point. But that's a great question or great point to make, whether or not they have protocol for this. But something else to keep a note of too is that the pulmonologists, they have like maybe 20 procedures that morning, and this is just another procedure on their checklist. They already saw this patient in clinic. Let's just say they got all the blood work they needed to. So they're kind of just like in the mentality of, okay, do one, next one, do one, next one. And bronchoscopy overall is kind of seen as like a very, I mean, it's kind of like colonoscopy, where it's almost seen as just very standard and not high risk. But we'll go into that some more. But great thought, Alex. And this is what kind of Dr. Patel mentioned already. I think the biggest thing that was lost from this case and what really broke my heart with the family was that they did not get the chance for their mother to go through palliative or hospice, and they didn't get the chance for that dignity to make that decision. And everything just happened so quickly. And here was somebody that was 82. She was older. She did have a lot of medical problems, but she was doing quite well for herself and still driving, still independent, didn't have any memory issues. She had a good quality of life. So for her to, lose out on these possibly 3 to 6 months of hospice that she got to spend with her family, I think that was, to me, the biggest loss of this case. And this is just one of the studies they did of many of hospice, about the satisfaction reports are as high as 87%. And then just as high depending on the the hospital care version versus the nursing home version, and so on and so forth. But lots of really good studies on the use of hospice and palliative overall, for our healthcare system and for the families. So one thing I wanted to touch on really quickly, won't spend too much time on this, but primary care physician burnout and ideal panel size. So this particular physician, this person had like 3,000 patients on their panel, something like that. And several studies have come out that show that in order for a doctor to take care of 3,000 patients in the typical, with all the issues in the US, they have to work 17 hours a day, 7 days a week, all year. So they would be an intern forever, essentially. And this is not okay. And nobody, of course, is doing this. So some corners have to be cut, unfortunately. Even the 2,500 panel is seen to have to work more than 21 hours a day to effectively do all the primary care prevention, effectively go through notes, effectively write and put in orders. And this is why, one of the reasons why burnout is so high in our primary care system. And the shortage is not really helping with that. And I haven't read this book, but it did pop up while I was looking up this topic. And it was he's like a CEO and has lots of experience with hospital management. And wrote about how on with his own research of tons of different hospital systems and clinics that he's seen, 983 was actually the maximum per doctor. That was ideal, and then up to 1,300 to 1,900 if you have a well-run team-based practice, meaning you have full staffing of your nurses, full staffing of the front desk, lab technicians, et cetera, et cetera. And then something to keep in mind too are some other non-traditional practice methods, especially for the burnt out physician, things like concierge medicine, the DPC, which we had Dr. Bernardi come and speak about, urgent care, virtual care. Right now, though, per the annuals of internal medicine, there is not enough evidence-based recommendations about like an optimal primary care size, just because there's so many variables, including like the patient population that you work in, and how sick they are, or how healthy they are, what their age is. So there's a too broad of a spectrum to really do a accurate study to make a recommendation about number exactly. That's the meta-analysis. So we'll talk a little bit about bronchoscopy. Some of the reasons for bronchoscopy would be like for this, in this instant, working up for cancer, inflammation. Other reasons would be like a persistent cough or hemoptysis without a source, wheezing, hoarseness, persistent lung collapse like atelectasis would sometimes prompt this. Risks of bronchoscopy, like we kind of talked about earlier, may be more likely if airways are inflamed or damaged by a disease. So that was what I highlighted as what stood out to me the most from that. Other things include bleeding in the collapsed lung and fever. And essentially a bronchoscopy, they go down through nasopharyngeal access to get usually either a look at things and then also to get a biopsy if needed. And then I was curious what the complication and mortality rate of bronchoscopy was, and it's extremely, extremely low. Per documented mortality rate was 0.013. So overall, it's an extremely safe procedure. Has been tried and tested even on this paper back in 1976. 48,000 procedures with 10 total deaths from the bronchoscopy. One thing to note, though, was for our patient, her cause of death was not post-bronchoscopy. It was the hemorrhage. And so how many of things could be directly related to bronchoscopy but are not reported as the cause of death is something to keep in mind. What classifies a death directly from bronchoscopy? I don't know the answer to that, just something I was thinking of that maybe could affect these numbers. And in the literature as well, there's been note of massive hemoptysis caused by neoplasm, and then certain factors that would exclude patients from surgical intervention. And what stood out to me the most, aside from inadequate pulmonary function, which I believe our patient was at the cusp of the inadequate pulmonary function with how severe her COPD was and with her history of a valve replacement. And of course, the concern of metastatic cancer, all these risk factors that she had that did not make her an ideal candidate for bronchoscopy. So this is just a slide really briefly on pulmonary hemorrhage. And this is a CT of pulmonary hemorrhage. And we can see through here, the pulmonologist had called this pulmonary arterial bleed, so bleeding through he suspected was through the pulmonary artery, which most of the times is seen in what we call the Swan's cath, which is not really done much, at least at Union. And the Swan's cath is the most common cause of a traumatic pulmonary artery embolism, and that's because this tube goes right through the pulmonary artery, and this is usually to help maintain volume status. So for monitoring of our ICU patients and for monitoring of fluid status, some hospitals will, for a closer fluid monitoring, will instill a Swan's cath. I don't know if anybody's ever seen one or has seen a patient with a Swan's cath. I personally have not. I don't think I ever saw one in Maine either.
I haven't seen one since I was a resident.
Oh, so it's kind of out there.
The last time I saw that.
It's pretty high risk, I think. So the risks outweighed kind of the benefits of doing that anymore. Pancreatic cancer. So it's usually diagnosed late stage, which I'm sure we are all aware of. 20% of patients are diagnosed with a stage that is still operable, and among them, the survival rate reaches 20% 5 years after the diagnosis. And the diagnosis relies on imaging to help clarify the size and metastases, especially towards the ganglia, liver, and bones. And the diagnosis can be confirmed if desired on biopsy. So one thing I saw on review of my patient's chart more closely was that her weight had dropped dramatically between just this small time span of like 5 months. From September 14th, 2022, she was 132 pounds. And when she was admitted for her bronch on January 20th, she was only 116. So almost a 20-pound difference. And she was not doing this on purpose. She was not losing weight or doing anything to lose weight on purpose. Very insidious. How common is pancreatic cancer? It is number 10 so far per the NIH. It's got a 5-year relative survival rate of 11.5 per 2012 to 2018 studies, and it represents about 3.2% of new cases. So what are the symptoms? Well, we already know about jaundice, talked about that one the most. Nausea and vomiting, poor appetite, abdominal back pain can happen, pale stools, and then also some findings of the gallbladder and liver as well. The diagnostic approach for pancreatic cancer would be starting off with a CT or MRI, depending on whether there's a mass lesion or not, would determine next steps. So if there was a mass lesion with distant mets, it'd be probably with a biopsy and non-surgical treatment, versus no mass lesion seen, follow up with the ERCP. If there's no tumor, look for other diagnoses. If there is a mass seen and the patient's a poor surgical candidate, then there'd be non-surgical treatment and discussions of palliative care, so on. If the patient is a reasonable candidate, then they may qualify for some type of resection and then biopsy. And then there's also some neoadjuvant therapies too, if they want to be very aggressive about treating it. There are 2 types of pancreatic cancer. So we know that the pancreas serves 2 functions. It has exocrine and endocrine functions. The exocrine helps with our digestive enzymes, secreting carbohydrates, enzymes that help break down carbohydrates, fats, proteins, acids. And these are adenocarcinomas actually account for more than 90% of pancreatic cancers. So they're the most common type. The neuroendocrine tumors are less common, less than 5%, and we know the neuroendocrine portion of our pancreas secretes insulin and glucagon, and these are kind of our popular med school tumors like insulinoma, glucanoma, and gastronoma. And that is the end of my presentation. So thank you everyone for participating and for being here to listen to this lecture today. Does anyone have any questions about anything?